Hello, I'm John Kellum from the University of Pittsburgh, and I'm going to sum up much of what you've heard regarding COVID-19 and acute kidney injury. My disclosures are shown for you here. There's really nothing that's particularly relevant to what I'm going to be talking about. So in the first place, we understand that the virus affects primarily the lung, but also can affect the endothelium in the lung and elsewhere. And in a subset of patients causes enough of a systemic inflammatory response that this affects other distant organs. And when this happens, it's really quite familiar to us. This is sepsis. This is viral sepsis, but it shares many of the features of bacterial sepsis, and the AKI that occurs from this mechanism is very much like the AKI that occurs in the setting of other forms of sepsis. However, there are also direct distal organ effects from the effect of the virus on the endothelium, and this is particularly true for organs like the brain, probably the heart. The data on the effect on the kidney is less clear, but there's at least a hypothetical mechanism whereby injury to the renal endothelium is causing some of what you see. And certainly there's a form of injury to the kidney that's a type of focal glomerular sclerosis, which may well be mediated through this pathway. But also, the virus may have direct viral infection in certain organs. This seems to be clearly true for the gastrointestinal tract. It may be true for the kidney. It doesn't appear to be true for the heart. In other words, there doesn't appear to be a viral cardiomyopathy that's happening. But for other organs, in particular the GI tract, and most likely the kidney, direct viral trophism appears to be another mechanism of injury to these remote organs. But beyond that, there are a variety of other effects which can occur. This symbol is a ninja, which is a call out to the ninja study from Stu Goldstein looking at pharmacologic effects on the kidney, drug-associated nephrotoxicity. In some group of patients, there's a more exaggerated inflammatory response, and this can injure the kidney. There seems to be a genetic predisposition in some patients and mitochondrial injury, and some patients develop rhabdomyolysis, which can affect the kidney. So there are a variety of different ways the kidney can be injured. And the most common way, though, appears to be because the lung is significantly injured by the virus. There's release of damage-associated molecular patterns into the bloodstream, which are filtered at the glomerulus and delivered to the kidney via the peritubular capillary, where they can signal with pattern recognition receptors, including toll-like receptors on proximal tubular epithelial cells, causing inflammation and injury in the kidney. This is a not uncommon scenario. ARDS has been associated with AKI in a number of different studies, and the risk of AKI, looking at effective ARDS, is approximately twofold. In other words, if there's development of ARDS, the risk for AKI doubles in whatever setting one is looking at. Now, there is also this idea that in a subset of patients anyway, viral illness, including COVID-19, can cause macrophage activation syndrome, or atypical HLH. And this causes an uncontrolled cytokine response, sometimes referred to as a cytokine storm. However, in the typical patient, the average patient that you see with COVID-19, levels of cytokines really are not that impressive. This is IL-6, and you can see this is much more of a cytokine drizzle rather than a cytokine storm, at least in comparison to other types of conditions such as septic shock from bacterial infection, in which cytokine levels are much, much higher than you see, and variable, highly variable. And of course, that's the issue, right? You can't just look at a few dozen patients with COVID-19 and make a case that there's not much inflammation, or there is a lot of inflammation, because there's a fair amount of heterogeneity. Also, don't forget, the only intervention that's really been shown to be life-saving at this point, apart from supportive care, is the use of corticosteroids. And of course, these are directly targeting inflammation. Now, whether they're targeting local inflammation in the lung, which of course they are, versus systemic inflammation, which they might be, is still unclear. And all we can really say is that for patients in which require at least oxygen, and those certainly who require invasive mechanical ventilation, benefit from the use of corticosteroids, which ostensibly reduce inflammation in the lung and elsewhere. Now, what about the epidemiology of acute kidney injury? I've put the percentages in for you here. This is the largest study to date looking at AKI in the setting of COVID-19 from the US and the New York City region. And you can see that about a third of patients develop acute kidney injury. Approximately half of those are stage 1, and the other half are stage 2, and about 14% require renal replacement therapy. These are remarkably similar data than what we see with bacterial community-acquired pneumonia. About a third of patients develop AKI. About half of that is stage 1, and the other half is stage 2 and stage 3. What about the impact on mortality? Well, this is data from the PROCESS study, in which you can see that it's actually pretty hard to die of severe sepsis, septic shock, without acute kidney injury. The 90-day, 60-day mortality rates were 6% for patients who didn't develop AKI, whereas they increased to 17% for patients with stage 1 and nearly 28% for stage 2 and stage 3. What does that look like in COVID-19? Again, looking at the Hirsch data, you can see that remarkably similar. If you don't develop acute kidney injury, you've got about a 6% mortality. If you develop acute kidney injury, stage 1 is, if anything, a bit worse, and stage 2, 3 is quite a bit worse, but still in the same ballpark as what you see with bacterial septic shock. So there's a dramatic effect, particularly when acute kidney injury is severe, on mortality. Now, is this coming from direct effect of renal dysfunction on survival, or is it a marker of severity of illness? Well, in point of fact, it's probably both. Kidney injury is a marker of severity of illness, but it's also directly in the causal pathway for mortality. Now, what do you do about this? What's the management? Well, I was fortunate enough to co-chair the first ever virtual ADKI conference this summer, where we explored all of these management issues. And sort of to summarize, if you think of the pathobiology, the mechanisms, is sort of fitting into 3 categories: direct viral effects, indirect effects, but both indirect from the virus, but also in the disease process, but also indirect from its treatment. And if you think about this in sort of 3 categories, then you have direct viral effects, you have indirect effects, and you have sort of clinical management effects. And then you can look at the variety of things that we would do. So standard of care to prevent multi-organ failure is, of course, important for all of these. Individualizing fluid management, avoiding saline has an impact on these. Consider functional hemodynamic monitoring, monitor serum creatinine and urine output, correcting hyperglycemia. Consider alternatives to radiocontrast and other imaging. Avoid nephrotoxic agents when possible, considering the risk of selected ventilator strategies, including high PEEP, which can reduce perfusion to the kidney, particularly when there's inadequate circulating blood volume. but also doing a diagnostic workup to try to sort out, is this related to drugs or is it related to the virus itself or something else? Consider alternate pharmacokinetics and dosing your drugs correctly, considering renal replacement therapy, and avoiding subclavian access for your lines, because this reduces the possibility of having a fistula later if you don't recover. Supportive care for these patients does matter clearly, and you have to be careful about fluids. Too much fluid worsens gas exchange. Too little fluid will worsen AKI and possibly promote hypercoagulation. Renal replacement therapy timing is uncertain, as it is in all forms of acute kidney injury. So acute kidney injury in patients with COVID-19, the epidemiology mirrors that of community-acquired pneumonia. The impact on mortality may even be greater. The pathophysiology is multifactorial, just like in sepsis. Damp-mediated toxic nephropathy is most common form. Nephrotoxic drugs, FSGS is uncommon. Direct viral infection of the tubular epithelial cells, if it occurs, it appears to be uncommon. Macrophage activation-like phenotypes are rare but highly lethal. The treatment, as per other forms of sepsis-associated AKI, supportive care, reduced lung injury, will result in less AKI. Careful fluid management, I can't stress this enough. Avoid saline and limit other nephrotoxins. Monitor renal replacement therapy requirement and deliver it when needed, and not wait until the middle of the night when risks are higher. So with that, I thank you for your attention.